So then a bit of a different topic, but I think surely an exciting one. We'll hear about whether physical activity is influencing our gut. So we'll hear about gut leakage markers in response to strenuous exercise, and it will be Susanne Aune who will give our talk. So thank you very much.
Thank you very much, Johannes, and thank you so much for the opportunity to present here today. I'm very happy to be here in person. My name is Susanne Aune. I'm a medical doctor and a PhD student at the Oslo University Hospital of Ullevål. And I will be presenting our study on the effects of strenuous exercise on gut leakage markers in patients with symptoms of coronary artery disease. So I will start by giving you a short background on coronary artery disease, gut leakage, and also on exercise before moving on to our aims and the study and results. So, coronary artery disease is, as you all might know, the narrowing of coronary arteries, often due to atherosclerosis. Well-known risk factors for coronary artery disease are listed here and includes hypertension, diabetes, and several lifestyle factors. However, in recent years, the gut microbiota and gut microbial dysbiosis and gut leakage has emerged as a new possible risk factor in coronary artery disease. Gut leakage is thought to contribute to coronary artery disease by contributing to a state of low-grade inflammation, and inflammation has proven to be of central role in the development of atherosclerosis. So, gut leakage. Gut leakage is the translocation of bacterial products, mainly lipopolysaccharide, or LPS, across a dysfunctional gut barrier and into the circulation. This can either happen by transcellularly, paracellularly, by the disruption of the tight junctions between the cells, or in the case of cell damage to the enterocytes lining the gut. LPS in the circulation will bind to LPS binding protein and soluble CD14 or membrane bound, and together activate the toll-like receptor 4 complex, which then will activate initial inflammatory signaling and activation. So these are what we call the gut leakage markers. And to gain additional information about the barrier, we can also measure intestinal fatty acid binding protein, which is an intracellular protein in the enterocytes lining the gut that will leak into the circulation in the case of cellular damage. So, moving on to exercise. As we all know, regular physical exercise has numerous health benefits, and including a reduced risk for cardiovascular disease and death. But strenuous acute exercise, on the other hand, meaning one single bout of strenuous hard work, is associated with increased risk for cardiovascular events. Strenuous exercise is defined as equal to or above 6 metabolic equivalents of task, meaning 6 times or more the energy expenditure of that when you're resting or sitting quietly. So, a transient increase in gut leakage markers has also been observed after strenuous and acute exercise. And the mechanism is thought to be exercise-induced disruption of the tight junctions between the cells, or exercise-induced ischemia to the gut and cell damage to the enterocytes. So strenuous exercise and gut leakage markers has so far only been investigated in healthy, endurance-trained individuals, and has, to our knowledge, never been investigated in patients with symptoms of coronary artery disease. We therefore aimed to explore gut leakage markers in response to acute strenuous exercise in patients with symptoms of coronary artery disease. And we also aimed to investigate whether there was any difference between patients who proved to have coronary artery disease and the different degrees of coronary artery stenosis. To investigate this, we included 287 patients with symptoms, or they were referred to the outpatient clinic due to symptoms of coronary artery disease. Blood samples were drawn before and within 5 minutes after a conventional ECG exercise stress test. All patients then underwent coronary angiography to assess the degree of coronary artery stenosis or degree of coronary artery narrowing. They were grouped in 3 groups. Significant coronary artery disease was defined as having previous PCI, above 75% stenosis, or any stenosis the angiographer considered clinically relevant. Non-significant coronary artery disease ranged from wall changes and all the way up to 75% stenosis, while no coronary artery disease was defined as having no wall changes and no stenotic segment. All blood samples were then analyzed for the gut leakage markers. The soluble CD14, LBP, and intestinal fatty acid binding protein were analyzed by ELISAs. LPS was analyzed by the KC-LAL assay method, while the relative gene expression of toll-like receptor 4 was analyzed by mRNA RT-PCR. So, moving on to our results. Our patients had a median age of around 62 years. They were mostly male, a slightly overweight, and the majority had hypertension. There was significantly more men in the groups who proved to have coronary artery disease than those who did not. Importantly, they exercised for a median of 9.5 minutes, and they all reached a median of almost 7 metabolic equivalents of task. We found that the gut leakage markers soluble CD14, LBP, and LPS all increased from before to after exercise, while intestinal fatty acid binding protein, the marker for intestinal cell damage, remained unchanged. As we know that these markers are released upon LPS stimulation of the toll-like receptor 4 complex, we next wanted to investigate whether the gene expression of toll-like receptor 4 was altered. And we found that the relative gene expression of toll-like receptor 4 decreased by approximately 22% after exercise. Next, we wanted to see if there was any difference between the groups, the patients who proved to have no coronary artery disease and the patients who proved to have coronary artery disease. And we found that there was no difference in change and no difference in relative change in the gut leakage markers between these 3 groups. So we also wanted to see if there was any difference between the patients who proved to have no coronary artery disease and the groups who had coronary artery disease taken together, but there was no difference in change in these 2 groups either. We concluded that even short bouts of strenuous exercise results in an increase in gut leakage markers. As intestinal fatty acid binding protein did not change, we believe that the observed leakage was due to para or transcellular leakage rather than to cellular damage. The reduction in toll-like receptor 4 gene expression might represent a negative feedback counterbalancing the transient inflammatory increase. And lastly, there was no difference in change between the different subgroups of coronary artery stenosis, and so we believe that gut leakage is independent of the presence of coronary artery disease. Lastly, I want to thank my supervisors and collaborators, among them Ingebjørg, who is here today. And the article is available online if you want to read the full thing. Thank you so much for having me.
So, thank you very much again for a very nice talk, which is open for questions. I was wondering, do you think this is damaging? I was wondering, do you know anything about the gut leakage when it's not that strenuous, the type of exercise that's supposed to be healthy? Do we know anything about that?
Yeah, so as I was saying, the most research in gut leakage markers and exercise has been done in healthy populations. And we've seen that there is a threshold in the healthy population, probably around 2 hours of exercise, of moderate to vigorous exercise. And some few studies have shown that it's not the duration, but it might be how high intensity there is. So we're not quite sure. But this is the first in coronary artery disease population, and these exercised for only 10 minutes.
It's very short. Thank you. Fredrik?
Thank you for a nice talk. Still
Thanks.
Fredrik Juhl from Rikshospitalet. I have 2 questions. Firstly, the patients that were non-coronary artery disease patients, how did the results there relate to other studies? You said there were previous studies on healthy individuals. That's the first question. And the second question, what is the rationale behind the gut leakage in these patients? Is it like a proxy when they have stenosis in the coronary artery? They probably have it in the intestine as well, or what is the mechanism? Why do you believe that these should have more leakage?
Thank you, Fredrik. The first question was whether
the non-coronary artery disease patients, how did the changes in this population, how was it compared to previous studies on healthy individuals?
Yeah, so it's the same as they have seen in other healthy, but what's different is the duration that in other healthy populations we've seen that it needs to be for a longer duration of time, the exercise. Other than that, it's quite the same. They also have the increase in LPS and the other markers. And to your second question, which was the rationale behind, is we know that patients with coronary artery disease, they're associated to gut dysbiosis. And so we know that they have less abundance of butyrate-producing bacteria, and we've also seen increased gut leakage in these outside of exercise. So we thought that since exercise has shown to induce gut leakage, even in healthy population, we thought that these having a gut dysbiosis in the first place, that they would have a higher or more pronounced increase in the gut leakage markers after exercise, which we didn't find. Yeah.
Thank you.
Thank you. Next question.
Hi, I'm Runar Vigen with BioMe. So these metabolic equivalents, right? That's relative to the resting metabolism. So if you have the resting metabolism times 6 for a patient with suspected or confirmed coronary artery disease, that's probably pretty tough, and that's the reason why they can exercise for 10 minutes while healthy can exercise for 2 hours.
Yes.
So when you compare your studies to the studies in healthy, how can you can you really compare these? I mean, what about, the other alternative would be to look at maximal oxygen consumption. You can't really test that in these patients, but you could maybe estimate it. And then you could do a trial where you do a relative percentage of your maximal oxygen consumption during exercise for the same amount of time, or it's just if you have a maximum consumption of 60 milliliters of oxygen per minute compared to a patient that could have 15 as the maximum, it's quite hard to compare these trials. Can you comment on that?
Yes, thank you. So I totally agree. It's very hard to compare these two groups because they are just so different. So these are patients in another. They're older. They use medication. They have other comorbidities. So it's hard to draw any lines with the healthy endurance trained. So most of them are athletes in the other group. So I agree. In this study, we didn't have the opportunity, unfortunately, to measure VO2 max, which would be a better, I agree with you, a better measurement. But we did that in another study where we looked at exercise intervention over a year, period for a year. And we found that patients with coronary artery disease with lower VO2 max had higher baseline levels of gut leakage markers. Yeah, thank you.
Thank you very much. Very brief question in the end, Maria.
Yeah. Hi, I'm Maria. I think I got an easy one maybe. I'm wondering, so how long does for how long can you observe the leakage marker after exercise?
This is thank you for the question. We've discussed this because we ideally we would have liked to have blood samples from 5 minutes and then maybe 10 minutes after and a half an hour to look at how do they progress over time. So unfortunately we didn't in this study. So what we know about these markers, especially LPS, is that it's rapidly increasing in the bloodstream and then it's very rapidly removed again from the bloodstream. So probably the strength is that we measured immediately after exercise in this case. For the other markers, soluble CD14, LBP, and also intestinal fatty acid binding protein, we know that they stay for a while, up to hours. I'm not sure exactly how long, but we know that they're more stable in the bloodstream. Yeah.
Thank you.
Thank you.
Okay, thank you very much.
Thanks.
Thank you for a great talk, and also thank you to all the speakers of this session. Now I think we'll have a short break and start again 12:15. Thank you.